of the marketing team at School Health. I'd like to thank you for joining us today and participating in our ECG in our schools webinar, the what, the why, and the how. Joining us today is School Health Sports Medicine Specialist Mike Klein, our Specialist Manager, Dr. Ray Heipp, and Emergency Preparedness Specialist Vince Pesavento. They have all spent time at the intersection of student health and emergency preparedness throughout their careers, and we appreciate all of them taking the time to talk to us today about this very important topic. If we want to kick it off, I'll pass it over to them. Before we begin, Vince is a paramedic, a parent, and a coach. Mike is also a certified athletic trainer, a parent, and a coach as well. And Dr. Ray is a former administrator and a parent and a coach himself.
Good morning, everyone. Nice to see everybody today. I want to kind of give you a little background on what is an EKG. An EKG is short for an electrocardiogram. What an electrocardiogram does, it will measure the electrical activity of the heart and also tell you how well that heart is working. The whole idea behind an electrocardiogram is to look for irregularities in heartbeats, also known as an arrhythmia, where the heart does beat irregular. It will also examine for possible heart damage there. The different types of tests when you do an electrocardiogram on someone would be when someone is resting. That means they're lying down flat. They will put this equipment on you and measure your heartbeat at rest. Then we have a stress test. A stress test is typically done when you are walking on a treadmill, and they will increase the speed of the treadmill and the height of the treadmill every couple of minutes and put some stress on your heart to see how well it is beating. During these times, they're monitoring the electrocardiogram, watching the rhythm of the heart, and making sure everything is responding accordingly. And then you have your single average, and then we go into more of an ambulatory one. This is one we might see more in the school settings, is where you're walking around with the piece of equipment on you, and it's just measuring your heart at walking. Next slide, please. Why is it important? It's important that we have our young students get a baseline. And what we mean by the term a baseline would be a very first initial reading of a heart rhythm. This is where in the future, when you have your baseline, that you can compare your very first one to your second one, to your third one, to your fourth one, and so on, to see if there's any changes within the heart's condition or how it's beating. So to get a student a baseline will give a student a good idea, and the parents, of how the heart is reacting currently before any activity is exerted or they go into sports. This will also help us identify, by doing this 12-lead EKG or electrocardiogram, identify issues before they appear in negative ways, where someone may be out doing a sport or activity and they develop that chest pain, they get lightheaded, they dizzy, they faint or syncope, and then they're getting more invasive treatments farther down the line. This is a great idea to help maintain the health of our students and our young athletes. Next slide. Mike, you can take this one.
Thanks, Vince. Why it's so important to be proactive with these ECG screenings is the fact that around 2,000 people under the age of 25 die each year from sudden cardiac arrest. Sudden cardiac arrest is the highest, or the number one killer for student athletes in the country, and is the number 2 cause of death for people under the age of 25. Sudden cardiac arrest is higher in males than it is in females. It's also higher in African Americans than it is in whites. This is why we want to be more preventative and proactive with these screenings. So a comprehensive screening would include an ECG or EKG, both kind of interchangeable. And basically what this does is it just takes a snapshot of the athlete or student's heartbeat so that any abnormalities or atypical heart rhythms can be captured and evaluated for any electrical or structural abnormalities that the doctors might be able to pick up when they review the test results. Next slide, please.
Thank you, Mike and Vince. One of the things we want to take a look at are states that already have guidelines or recommendations. We're going to discuss Florida and the Second Chance Act in a moment, but that is a mandatory act that's already taken place. In Texas, we've got Cody's Law, and this is a law that requires information about student athletes being shared so that, again, they can be evaluated properly. In Pennsylvania, we've got Peyton's Law. And this is more a focus on the awareness, that whole idea of preventative medicine going in, getting these ECGs in beforehand so we get an idea of where that student athlete is. In Tennessee, we have the Safe Stars Act, and this is setting up protocols throughout the context of how we're actually operating with our student athletes out in the field. Next slide, please. For Florida, the Second Chance Act actually began in July of 2025, and they're going to be formally enforcing it beginning with our upcoming school year, the 26-27 school year. And what it's doing is it's requiring schools, secondary schools, to make sure that every student athlete has an ECG prior to any participation in a secondary level sport that includes freshman, JV, and varsity levels. The idea is that if they are able to detect some of these issues beforehand, the students can be placed under the care of a physician so that they can safely participate in the future and not have any unforeseen issues that might arise. Now, there are some opt-outs that are permissible under this Florida law. It could be for religious or medical reasons, or also Florida is capping how much a school can charge for this at $50, trying to make sure that, yes, we're keeping our athletes safe, but recognizing that sometimes the families may be struggling at home too. Anytime that there are abnormal results that are showing up, a student must be medically cleared before they can have any participation going on in an effort to make sure they're protecting that student from, again, a potential issue. Next slide, please. Vince, if you don't mind, would you go ahead and pick up from here a little bit?
Wonderful. There are a couple of types of ECGs suitable for use in a school. They're very basic and very easy to use and very user-friendly. The first one is going to be the QT-PC 500 from QT Medical. It's a rather small unit, and I'm going to go into more features of both the units in the next two slides. And then we have the Baxter CP150. Next slide, please. So the PC 500 is a small 12-lead ECG that is extremely easy to put onto a patient. As you can see, the person is holding it in their hands. It's about the size of a cell phone, if not a little bit smaller, and extremely lightweight. The big advantages of using the QT Medical product is the QT Medical product is all done on an app-based service, and it is Bluetooth. Also, if you notice in the picture of the person with the leads on them, the leads are all connected in one continuous pad. So you do not have to actually go over the chest, and where you would have to palpate the ribs and feel for the right intercostal space and knowing between what rib you are and that you're down your midclavicular line. It's more of what we consider a uni-pad. Now, it does have separate arm leads that you have to put stickers on the arm, and it does have one lower lead that would go under the abdomen as a lower leg one. The rest of the leads, because when you're doing a 12-lead EKG, they come through leads V1 through V6. I'm not going to go into the technical terms of what each lead does, but they are different ways they read the heart. So on this pad here, V1 through V6 is one giant sticker. Now, how would you size this? There are several different sizes and a chart inside the QT Medical product that would help you size the appropriate pads between a child and adult pad. Once you place it on, let's say you put someone in a supine position and or laying down on their back, you would put the sensor in the center of their chest, and it would connect either to possibly an iPad, an Android device, or your iPhone. It would give a tracing. You would put in the patient's information, and it would spit out a 12-lead ECG right to your phone. Now, the 12-lead ECGs are interpreted right there, but it is recommended that a physician and or doctor give the official interpretation of the 12-lead ECG. This is 70% faster lead placement because the leads are all there and you're not palpating the patient. And is perfect when we have a mass screening or you're screening a lot of athletes in one time. Next slide, please. So this is the Baxter and or Welch Allen touch display 12-lead ECG. One of the differences between this is the Baxter 12-lead or CP, 150 has a couple different options. You can do a 3-lead contiguous monitoring, meaning that you would put 3 leads on a person, one here, and then one below the abdomen, and you can see the heart contiguously all the time. The downfall to that is it's not an invasive view of the heart. But this machine then allows you to put on the additional leads to get that invasive picture of the heart called that 12-lead EKG. This unit will take a little bit more time to put on, as you physically will have to palpate the patient starting up here below your intercostal space, and you're palpating the spaces between the ribs to find the right location of the patient. Once it's on, it is hooked up usually by USB or an Ethernet cable. It will give you a reading right on the display, and then you would capture the person's heart with it, and then it would spit out on a piece of paper exactly what the heart rhythm is. This one is a battery or plug-in option, as the prior one is a battery operated unit. You just need to charge it via USB. It only takes about 4 to 6 hours to charge to a full charge and can last you roughly, I think, about 50 to 60 patients before you have to charge it again. The other option, the other unit to the QT medical one, there you can upload those 12-lead EKGs to a doctor right away. Where this unit, you would have to have a doctor and or physician on the scene, cardiologist, reading those, or you would have to take them somewhere to be read. Next slide, please.
Thank you for that, Vince. Appreciate that. Now, people are always asking, okay, what are the best funding avenues to try and get a device like this into our schools? Well, ironically, as this is first coming out, we're not necessarily seeing any specific grants that have been made possible for these types of units. So in going back and analyzing and talking to former colleagues, there's several different approaches we may want to take along the way. The first one is to bring together your health services department, your athletic department, and your extracurricular department, and make sure that you find some line items that allow those 3 groups to all put in some funds that could be used for the purchase of one of these devices. Why bring in all 3 of those areas? Well, health services, obviously, we're trying to make sure that the students are staying healthy. But in athletics, obviously, they'll be testing all of their athletes going in. The extracurricular side is for some of those areas that may be still requiring students to actually do some type of activity. And I'm thinking of our cheerleaders, who are excellent athletes to begin with. I'm also thinking of our marching band as they're getting out there. And that's why you want to have extracurriculars in there as well. You can also check with your local county board of health. In some instances, they may have some funding that they share with the community for specific types of devices. Because this is the proactive side of watching for sudden cardiac arrest, they may be able to take some of the funding that they have for AEDs and share it with you along the way. You also want to sit down with the athletic boosters and some other parent groups. I know in working with our boosters and working with the PTOs that were at my schools along the way, they were always asking, what can we do that's going to better the school community as a whole? And obviously a device like this would allow for that type of positive health support along the way. You can also ask local hospitals or doctors if they would be willing to support you with this and perhaps even sponsor a unit coming in. And I'm going to combine that with the idea of include it in the fee for athletic or extracurricular physicals, because oftentimes you have a doctor coming on site. You know, we had certain groups of doctors who every year would volunteer their time to come in. We would charge a fee. They would have that sports medical physical that went on and then would go back to whatever campus they came from. Well, this might be a way as they're coming out onto the field or coming onto your site as well to actually make sure they're doing a more comprehensive physical. And if they're supporting you with this, perhaps you change the rate for those student physicals, maybe from $25 to $40, so that the doctors who are involved can actually get some of that money returned to them in the long run. Another group that you may want to take a look at is any local nonprofit that actually is focusing on AEDs and AED support or other types of sudden cardiac awareness. Why? Because again, with this being the proactive side, the AED being the reactive side to protecting our folks out there, there may be some funding that can be shifted your way so that you have a more comprehensive approach to taking care of these student athletes and perhaps anyone else that you are taking a look at supporting from a health way. Next slide, please.
All right, Dr. Ray, thank you so much for that wonderful information. Here's some things coming from my side as a paramedic and the view of why I think this is important. First, the what. It is a simple process to do, especially with the QT medical device being one unipad, one pad, and no palpation required, just utilizing the measurement tools that come with it. You can put it on rather quickly, and it will test the electrical activity of the heart. And again, the what? The dysrhythmias. Some students may not know they're having dysrhythmias or that their heart's beating funny. They may feel other symptoms, dizzy, lightheaded, and they may just shake it off and not realize it is going to lead up to some cardiac event. Why are we doing this? As Mike talked earlier in the presentation, sudden cardiac arrest can strike a healthy young athlete anywhere. Roughly 2,300 students and young athletes will go into cardiac arrest a year based on the American Heart Association statistics. Many of these cases have been undiagnosed heart problems where this unit, taking a 12-lead EKG, can help diagnose through early detection and help save their lives and get them the proper treatment needed. The how can we get it implemented? Well, school nurses and or athletic trainers can apply these leads. They're extremely simple, especially when you just have that unipad and you just measure and you put it right on the person. We do, as I said before earlier in the presentation, we need it interpreted by a physician or a cardiologist to interpret it. Even though the machine tells you what it is, you want them to look, because the machines are very, very, very accurate, but you want to always have that cardiologist or physician look at it in case they find maybe a little anomaly that the machine didn't pick up. The great thing is we can partner with hospitals, EMS systems, telemeds, or nursing facilities that have traveling nurses to help us with this. And if someone does have an abnormal finding, we want to get them in for an evaluation to follow up with their medical director or, medical doctor to get treated right away. Some of my takeaways, again, prevention is as important as intervention with this. We want to get this prevented. We don't want to see these young athletes collapse, and we're applying defibrillators, shocking them and doing CPR and bringing them back, and then they're having long-term effects from this. ECG in schools shifts us from a reaction, again, to prevention, as Dr. Ray mentioned recently in the last slide, protecting students before a tragedy strikes. All right, Mike, it's up to you.
Thanks, Vince. Well, again, from an athletic trainer's view, obviously you've caught on that prevention is a huge message in this webinar. And Obviously, prevention is a key pillar in athletic training. That's why it is so important to have these screenings done for the athlete. And some of these conditions that can be detected by a 12 lead ECG unit that aren't detected otherwise in a normal physical would include arrhythmias, ventricular hypertrophy, pericarditis, ischemia or poor blood flow. Congenital heart disease is huge. I mean, that's a huge factor that you're always seeing athletes, after something happens, unfortunately, then the congenital heart disease or structural heart issues are detected. Long QT syndrome is another issue that is detected by this, and conduction system abnormalities. Sometimes the electrical wiring, quote unquote, just isn't working right. All of these can lead to sudden cardiac arrest, but they can be treated if detected early. And as an athletic trainer, I would love to have an athlete, not be able to play a sport and live a longer, healthier life, than to have their life taken away way too soon. Next slide, please.
So as I come in, first of all, I want to thank Mike and Vince for the ideas that they've shared. Mike and I were discussing right before we got on here for the webinar about a young man who was at a high school local to me that actually suffered sudden cardiac arrest, and he was part of the cross country team. I'm a former cross country coach, and that's one of the most frightening things. I can't imagine what went through the mind of that coach, let alone the mind of the parents as things were going on. Because all too often, and Mike can attest to this, you've got one athletic trainer at a high school. Well, if you've got a football game, a soccer game, and several things going on all at the same time, you can't be in multiple places at once. And therefore, the head coach is the one that has to take charge of what's going on. This is not a situation that's as simple as just putting a Band-Aid on an open cut. And so as an administrator, I want to make sure that all of my teams, all of my student athletes, and all of my coaches are protected so that they're not having to go through a situation like that. And we've got to be careful. We make assumptions about these sports physicals. Well, guess what? We don't always know what's going on. There may be some doctors that are going through just some very basic things saying, yeah, okay, this student is ready to go. Then there may be some doctors who, because they have the knowledge and the equipment, take it one step further. So we want to make sure that, again, on that prevention side, we have the equipment that allows that one step further to take place. We can't, as an administrator, I can't leave out groups like cheerleaders and my marching band. Why? Because guess what? That marching band is out there on the same field in the same conditions that our athletes are in. And we cannot presume as an administrator that our kids are coming into that secondary building healthy. For some of our kids, they may never have been to a doctor based on where they're at. Why? Because they've always seemed healthy. And so what we're doing now is we're just taking precautions to protect our kids. We can't have that reactive approach. It's interesting to me as I'm seeing this start to take shape with various states and the laws and the recommendations they're putting forth. It reminds me of just a decade or two ago when we started talking about moving AEDs into the buildings. There's a hesitancy. There's a cost associated with that. And there are way too many people saying, why do we need that here? Without the understanding that, we need these types of devices here to protect our students, to protect them from issues they may not even know they're dealing with. So as you're considering the adoption of something like this, recognize that, yes, you still should have the AEDs, but maybe get one less AED and add in an ECG at that secondary level that can be shared between the teams, maybe even in a district shared between one or two buildings. Just don't overload it. We do, and you keep hearing me say secondary, we want to focus on that high school level. The reason being is when you're using an ECG for athletics, really it's best to start looking at the students when they're about 12, 13 years old. And the reason for that is there's still a lot of growth and development going on, and you don't want to have a negative reaction as students are still, their bodies are still growing. And so focusing in with those secondary students, with those teams at various levels, with the marching band, the cheerleaders, and other groups that go into activities. Oh, and by the way, secondary administrators, all of our kids take physical education as well too, so consider that going in. These are all things that we should align ourselves with and recognize this is a device that can save lives and really not put us into a react mode, but instead being proactive. Next slide, please.
Thanks for this great information, Mike and Ray and Vince. I have a few additional questions for the team as well that I would like to ask the three of you right now. We will start with Mike. What is the best protocol for placing the heart sensor on females? I know as an athletic trainer, you work with athletes of, different backgrounds and genders.
Yeah, I'm going to throw this over to Vince because Vince has a lot more experience in his paramedic career placing these electrodes on females, if that's all right, Ellie.
Sure thing.
All right, Mike, thank you so much. In regards to that question, the best thing to do is always try and have someone as the same gender in the room with the person when you're conducting these 12 lead EKGs. Now, that's not always possible, but maybe you would have to redo it or invite the school nurse, and if it's a male athletic trainer who's doing it, so the school nurse just is in the room there with that. You can utilize and leave a sports bra on, but it does get a little bit difficult, especially with the uni pad going under. If you have to, and when you place the leads on a female patient, the leads have to go from the right side of the chest here, down below and underneath the left breast. What you want to do is take your hand, and even if it's male or female with the patient or the person you're putting leads in, use the back of your hand to push up the breast and your palm facing outwards. You don't want to take the hand and grab the breast and lift it up, because some people can say that is groping or manipulating your breast. So we always recommend using the back of the hand and pushing the breast up.
And Vince, to continue with you, why is it important to do ECGs on young athletes in general?
Well, like I said earlier in our presentation, we don't know as a young athlete that we have any underlying heart issues. As a young athlete, we want to be out there on the field, playing baseball, on the basketball court, shooting hoops, going and running those routes as a wide receiver for football. And we're going to kind of ignore some of the things that go on. Oh, it's just a little pain. It'll go away. It'll go away. Doing these ECGs will help these young athletes possibly detect an underlying heart rhythm they may not know they have. They go more in depth than your routine physical. I have a 12-year-old that plays in elite travel baseball all over the U.S. I had him get a 12 lead EKG this year at his yearly physical, so I have a baseline where he's at. These conditions that young athletes can have, the abnormality of heartbeats, atrial fib, atrial flutter, can cause conditions that can lead into sudden cardiac arrest during intense physical activity. And the early detection will allow for the appropriate medical evaluation, treatment, or activity modifications for the health and safety of that athlete.
Vince, I know you talked a lot about the different kind of conditions. So, Mike, are there any conditions that the QT unit wouldn't pick up or that they may miss?
Now, with both of these units, they're going to detect anything that a normal 12, not to say normal, but any 12 lead device, it's the same thing, whether it's in the hospital or clinic, or we're doing the screening in the school, they're going to detect the same type of conditions. Now, the important thing is to make sure you have a physician or cardiologist reviewing these and evaluating them. They might need further testing, like a cardiogram to, further look at the results. But these devices are basically the same things that you will see in a hospital or clinic, so you are good to go.
Vince, can a school nurse or an athletic trainer place the ECG leads, and who reads the ECG and provides the results?
Absolutely, a school nurse or athletic trainer can. Yes, there's going to be some training needed to go over on how to place the leads. For example, with the QT medical, you would have to just show them how to use the sizing chart appropriately, and then how to place the leads and take them off of the paper and apply them to the chest. With the Baxter, the CP150 unit, it's a little bit more invasive, so there's a little bit more palpation going on to find the right lead placement. But definitely, once you've learned it, it's really easy to keep going back to it, and training is rather easy on it to place the leads. And once the readings are done, no matter if it is the QT medical where it prints out right in front of you on an iPad and tells you what the heart rhythm is, or if it's the Baxter CP150 unit that gets you a paper printout, they all identify what the heart rhythm is currently in. But to get the accurate reading of the heart rhythm, it definitely needs to be done by a qualified healthcare provider, usually a physician and or cardiologist, to read those. And that time, if they see any abnormalities, they're going to request a follow-up with your primary care physician or possibly an ER visit.
Dr. Ray, why can't I just rely on standard athletic physicals?
One of the issues is that we say standard athletic physicals, and there's nothing standard about them. It's always dependent upon the doctor who is actually conducting them and what their understanding is of what the student needs. And even within that idea of the quote unquote standard athletic physical, reading the heart has not been a part of that up until this point in time. And so what we want to do is make sure, again, that prevention is happening, and we can't assume that it is happening. Some of our kids may be running to a local drugstore and getting a physical there if they have that ability. Some are doing it on site. We'd prefer to have them do it on site with a device like this, so we have a little more control and, most importantly, awareness, so we can best support the students.
Is there a grant I can apply to get an ECG device?
So we're still at the early adoption phase of bringing these devices into the schools. So even in the state of Florida with the Second Chance Act, what they recommended is a partnership, partnering again with a local doctor or partnering with a county board of health. My suggestion is the same. Partner with someone in the field that you trust and work to get those funds in. Maybe even just bring in the boosters, but make sure when you have those doctors coming in for the physicals, they're able to utilize the machine and give the best possible results.
This is fantastic information about ECGs. Thank you, Dr. Ray and Vince and Mike. That is all the time we have today. Thank you for joining our session on this very important topic. And if you would like to learn more about ECGs and how school health can support you, please visit us online at schoolhealth.com. Thank you.